Glomerulonephritis is an inflammation of the glomerular capillaries, and it usually follows a streptococcal infection. It is an immune complex disease. It is not an infection of the kidney. It exists as either an acute, a latent, or a chronic disease. In acute glomerulonephritis, insoluble immune complexes develop and become trapped in that glomerular tissue, and then we see swelling and capillary cell death. So we're going to see a decrease in glomerular filtration rate. Prognosis varies depending on the specific cause, but spontaneous recovery generally occurs after the acute illness phase. In chronic glomerulonephritis, the patient this can occur in a patient without a previous history or a known onset. It involves a progressive destruction of the glomeruli and eventually hardening or sclerosis of it. It is the third leading cause of end-stage renal disease, with prognosis varying depending on the specific cause, but it's not good. So the risk factors that we see are immunological reactions. Primary infection with group A, beta hemolytic strep, is the most common. So group A, beta hemolytic strep infection is the most common cause. And also we will see it with systemic lupus erythematosus, perhaps from vascular injury, from like hypertension, metabolic disease such as diabetes. We could also see it with high protein, high sodium diets that can lead to glomerulonephritis. And older adults tend to have decreased working nephrons, and so therefore they're at risk for chronic renal failure, an increased risk. And they can report vague symptoms like nausea, fatigue, and achy joints that can mask their glomerular disease. So what kinds of signs and symptoms do we see? Renal symptoms. So we'll see a decreased urine output, a smoky or a coffee-colored urine or hematuria. There might be protein in the urine. We'll see a fluid volume excess symptoms. So what do we see with fluid volume excess? Well, those are the short of breath, orthopnea, rales when you listen to their lungs, periorbital edema, mild to severe hypertension. So that's the fluid volume excess symptoms. We may see a change in level of consciousness, anorexia, nausea, headache, back pain. With acute glomerulonephritis, we'll see the fever, and with the chronic, we will see the pruritus, which is itching. Lab tests. First of all, we want to get a throat swab to culture and see if we've got any strep A and group A beta hemolytic strep, or any type of strep, any infection. We're going to look for a serum BUN and creatinine. We're going to look for a creatinine clearance, the urinalysis for proteinuria, hematuria, cell debris, so they'll be looking for casts and red cells, and the increased urine-specific gravity. Electrolytes that we will look at would be hyperkalemic, hypoalbuminemia, hyperphosphatemia. We may do an ASO, which is an anti-streptolysin titer. So we're looking for the presence of strep antibodies. We're going to look at an erythrocyte sedimentation rate, WBC count, and a glomerular filtration rate, a GFR, which is the filtration rate of the kidneys. It's the best indicator of kidney function. Other diagnostic procedures would include flat plate KUB, a renal biopsy to confirm or rule out the diagnosis, and in acute glomerulonephritis, dialysis could be an intervention to treat severe uremia, which would be a large amount of urea and other nitrogenous wastes found in the blood. Nursing care includes monitoring daily weight and note any recent weight gain. I&O, we're going to look at changes in their urinary pattern, look at their electrolytes, their BUN, their creatinine, do they have pruritus. We're going to maintain bed rest to decrease metabolic demands, and their dietary restrictions. A fluid restriction, 24-hour output plus 5 to 700 mils. A sodium restriction and a protein restriction if azotemia is present, which equals an increase in their BUN. Their medications, we're going to give antibiotics on time to maintain blood levels so we can eliminate that strep infection. We're going to give them diuretics to reduce edema, use vasodilators to decrease blood pressure, and administer corticosteroids to decrease any inflammatory process. Nephrologists will probably be called in to consult to manage the renal function, and nutritional services will be consulted. We'll need a dietitian for dietary modifications and fluid restrictions. Other treatments that may occur are plasmapheresis, which is a method that filters antibiotics out of circulating blood volume, and if we are doing that, we need to monitor carefully the individual during this procedure and make sure that we use appropriate interventions to reduce the risk of coagulation happening. We want to encourage them to rest during this process to conserve their energy. Once a patient is discharged, home care may be used if the patient is homebound or in a nursing facility. Usually they're going to set up the patient's medications and any labs that need to be followed up. We want to make sure we do patient education for their meds. We want to instruct them to weigh themselves daily, and to same time, same clothing, same scale, and to notify their doc for any weight gain of 2 pounds in 24 hours or 5 pounds in 1 week, and advise them to maintain a sodium and fluid restriction. And like I said, we may need a dietary consult for that. We want to educate the client and the family regarding their disease and encourage expression of their feelings. Our total outcomes for these individuals is we want them pain-free, we want to maintain their fluid balance, we want to improve their tolerance to activity, and we want them to follow their medication regime.